Hello everyone and welcome to this afternoon's webinar on coordinated assessment. My name is Christy Greenwald and I'm the Director of Housing Policy and Research at the U.S. Interagency Council on Homelessness, and I will be moderating today's webinar. We have two great presenters here with us today. We have Ann Oliva, the Director of HUD's Office of Special Needs Assistance Programs, and Matt White, the Senior Associate with APT Associates, one of HUD's technical assistance providers. Before we get started, I have just a few housekeeping notes. First, the call is scheduled to last. We actually scheduled the call for an hour and a half. We know there's a lot of information we want to cover on today's topic, and we did reserve between 15 and 20 minutes for questions at the end of the webinar. We know everyone is busy, so we will do our best to stay on schedule and wrap up on time. As mentioned, we've reserved time for questions at the end of the webinar, but please feel free to submit your questions to us throughout the discussion. As they come up, just type your questions in the question box along the GoToWebinar toolbar and hit send. We, of course, won't have time to get through everyone's questions on air, but seeing all of your questions actually helps us a great deal. It helps us to understand what type of technical assistance materials are needed moving forward, so please don't be shy with the questions. We are actually trying to get the slides posted to the HRE. We know folks have been asking if they're posted yet, and hopefully they will be up in the What's New section on the home page very shortly. In addition, today's webinar is being recorded and will be archived on both the HRE and USICH website within the coming days. And we have a large number of folks on the call today, and actually still have folks joining us as I speak. Due to the large number of lines, there can sometimes be a short time delay as we move from one slide to the next. So please just know that that's normal, and we'll move along as quickly as possible. And lastly, I wanted to mention that we have a few polling questions that we'll be asking throughout the webinar. It's kind of a fun way just to see where everyone is at on this topic, so I want to encourage everyone to participate in those as they come up. Okay, so 2 weeks ago, USICH and HUD conducted a webinar on retooling your homeless services system from one that manages homelessness into a system that quickly and effectively resolves it. And those of you that joined us will recall that we presented a new framework for thinking about how to organize and deliver homeless assistance within your community. That framework was based on 3 A's: access, assessment, and assignment of a permanent housing intervention. This is admittedly a simplified model of how things work in the real world, and of course the concepts of access and assessment are highly intertwined. And so in today's webinar, we wanted to take a deeper dive into the topic of coordinated assessment to examine what the purpose and the benefits are, the various models that exist, and the pros and cons related to each model. We'll take a look at some real-life examples of how communities in a variety of circumstances have implemented coordinated assessment, and in doing so, we hope to provide you with the information needed to either start this conversation in your community, or for those of you that have already begun discussions, to move towards planning and implementation. Before we go any further, I'd like to administer our first polling question just to get a sense of who's on the call with us today. And so that's coming up on your screen right now. Of the roles identified or the categories identified on the screen, please just choose the one that best applies for you. So are you a homeless assistance provider? Are you associated with your continuum of care lead agency, local government, a technical assistance provider, or other? I'll give folks a few seconds to answer. Okay, so we have lots of, about 40% of the folks on the call today are service providers, about 20% are with the continuum of care lead agency, and another nearly 20% with local government, and then the rest mixed among technical assistance providers and other. Okay, I want to begin today by describing what coordinated assessment is, as this will really lay the foundation for the rest of our discussion today. Those of you that joined us for the webinar on May 6th will recall that we talked about some of the principles of effective crisis response. And those include things such as people know where to go for help and can easily access assistance. Assistance is client-centric as opposed to program or agency-centric. People spend the least amount of time in homelessness possible, and the focus is on quickly stabilizing people in permanent housing. And assistance is just enough to help the client achieve and maintain housing stability. Simply put, communities across the country will have to embrace these principles if we are to meet the goals outlined in the Federal Strategic Plan. Those goals are ending chronic and veteran homelessness by 2015 and ending homelessness among families and youth by 2020. And we at USICH feel that coordinated assessment is a really powerful tool for helping make many of these things a reality. When we think about a system of coordinated assessment, there are a number of components that are actually part of that system. So things like access points, how are people going to access assistance, screening and assessment processes, information about available services and programs, real-time knowledge about program inventory and capacity. It involves referral and waitlist management, and of course enrollment and admission decision criteria. And as we move forward through this webinar, we're going to explore all of these things in more detail. And the benefits of coordinated assessment are many. By having a consistent process for assessing client needs and making referrals, it allows us to better target available resources and stretch our resources to help as many households as possible. We all know that the demand far exceeds available resources, so we simply have to get better at matching interventions to the specific needs of each client and keeping a laser-like focus on what an individual or family needs to obtain and maintain housing. There really is no such thing as one size fits all. And by improving referral appropriateness and coordination, we can also reduce the amount of time households spend in homelessness and improve housing outcomes. In addition, coordinated assessment provides opportunities for improved data. Many communities that have already implemented coordinated access have found that their data quality has improved simply by just streamlining data entry. And the benefits of improved data are many. We know that data is really essential for program and system planning and monitoring. And at this point, I'd like to turn things over to Anna Leva, who is going to share HUD's perspective on why coordinated assessment is so important. Ann?
Great. Thank you so much, Christy. Good afternoon or good morning, everybody. It's nice to have you all on the call, and thanks to the USICH for having me join the call today, because this is a really important topic to us, as well as the Interagency Council. And I want to talk a little bit about why we really want folks to think about and do coordinated assessment. And when we talk about coordinated assessment from the HUD side, we largely draw from our experience with two programs in particular. The first is the Rapid Rehousing Demonstration Program that was funded in the 2008 Continuum of Care competition. We actually have been conducting a demonstration with 23 communities who won those funds in that competition and have had an opportunity to learn from them about what's working and what's not working. One of the requirements of the Rapid Rehousing Demonstration Program was the implementation of a coordinated or centralized intake and assessment system. So that's one of the places where we draw some experience. The other, of course, as many of you know, is the Homelessness Prevention and Rapid Rehousing Program, or HPRP. HPRP, of course, has been our biggest experiment to date in that a lot of communities took the HPRP resources and implemented a coordinated assessment model so that they could really understand the needs of the people who were presenting for homelessness prevention or rapid rehousing services. And HPRP, because of the size of the grants that we were able to provide through the Recovery Act, was a resource that was new to many communities, and it gave them the opportunity to build this kind of capacity locally. As we were developing both of those programs, we actually did quite a bit of legwork, and we reached out to continuums of care across the country that had these kinds of practices already in place. We're going to talk about some of those models later on in the presentation. And we tried to understand those models, what they had in common, what worked well and what didn't work well, in that we realize that there are many types of models based on what the community structure, homeless services structure is, whether it's in a rural area, whether it's in a big city, how much local capacity there is, what kind of other funding sources are coming in. For example, the city of New York has very large funding source from the city itself and from the state. So, those funds could have been used to implement these kinds of models. But what we really learned is that while the models themselves reflected very much the community structure and could have looked different in different places, they really relied on the same basic set of core principles. And we're going to talk about those principles in today's presentation. The other thing I would raise here is that as we were developing, I had the opportunity to work very closely with the Interagency Council in the development of Opening Doors, the Federal Strategic Plan to Prevent and End Homelessness. And what many people don't know is that as we were developing that document, at HUD, we were actually setting numeric targets for various kinds of interventions that we thought we would need to meet over the course of the 5-year and the 10-year period of the plan. And through the discussions that we had around the FSP, it became incredibly clear to us that in order for those interventions to work the way that we intended them to work, that communities would have to move to a more coordinated approach so that families and individuals who are presenting either as homeless or at risk of homelessness really could be quickly moved into the right kind of intervention for them. Next slide. And just for anybody who needs to know, we're on slide 8. And that sort of segues me into a discussion of the HEARTH Act and how all of these things coordinate together and should come together at the local level. The HEARTH Act is clear if you look at the language that it contains, that it envisions that the programs funded by the HEARTH Act are a key part of an effort locally that really is aimed at minimizing the amount of time that people are homeless. So these interventions should be designed to not keep people in the homeless services system, but really to get people out of the homeless services system as quickly as we can. And I think that that's something, a value that all of us share as practitioners. So, that mandate in the HEARTH Act, along with what we learned through the Rapid Rehousing Demonstration Program, HPRP, and the development of the Federal Strategic Plan, really showed us that we needed to move in the direction of the coordinated assessment system. So the HEARTH Act itself requires system-level outcomes for the first time, which means system-level performance and planning in a different way than what we've been doing over the last 15 or 20 years. And here's just an example. Many of you have heard me say this example before. That is, instead of looking at performance at the project level, which means for us right now in Exhibit 1 or the Continuum of Care application, you roll together the APR results for all the different projects by type, and you give us those as your outcomes. And while that's important to look at the project level outcomes, what's even more important, I think, is to be able to look at system level outcomes, such as the mean length of time that a family or individual is homeless within your system, or the rate of recidivism. So in order really to get that better system level performance, we need to make sure, as I mentioned earlier, that the needs of the folks who are coming to us for assistance are really matched in a coordinated way, in a comprehensive way, to the services and housing interventions that are most appropriate for them and that will get them out of the system as quickly as possible into a stable, permanent housing situation. And we've incorporated these lessons that we've learned into the regulations. For those of you who have had an opportunity to read the Emergency Solutions Grants regulations and the preamble that goes along with it, you'll see that we talk about coordinated or centralized intake as something that we want the ESG grantees to participate in. However, where we really puts the level of responsibility for the development of a coordinated assessment model is with the continuum of care. As a quick update, we do expect that the continuum of care regulations will be out soon. They are at OMB being cleared through the rest of the federal agencies, and we do expect them to be out soon. But what you'll see in the continuum of care regulations are really sort of the structure that we are looking for in terms of coordinated or centralized assessment, and how continuums really should be ensuring that ESG recipients are also participating in coordinated assessment models. So all of that to say that even though the regulations are not yet out and in front of you, we do think we want you to start planning as soon as possible, which is why we're doing these webinars. So I'm going to pause for a moment, and I'm going to administer our next polling question. And because I don't have my glasses on, so I'm not totally sure that I can see that. Okay. The question is, characterize your community's status related to coordinated assessment. And you have 4 options. Our community already has a system in place. We have it for one population but need to expand. We've been discussing our planning, but haven't started, and we're just beginning to explore options. I would say for those of you who are maybe even in the phase before we're just beginning to explore options, you should just choose that, response, and we'll see how many folks are in there. So we'll give you 20 seconds to go ahead and respond. Well, this is actually pretty good. About 32% of you have been discussing or planning, although you haven't started implementing, but it's good that folks are really understanding that we are hoping that you're going to be in the discussion/planning phase. 15% have it for one population, and 12% of you already have a system in place. For 40% of you, it's good that you're on the webinar today, and we're going to keep talking about this as time goes on and we implement continuum of care regulations to help get everybody up to speed. And with that, I think I'm going to turn it over to Matt White from Apt Associates, who is one of our senior and very experienced technical assistance providers who has done a lot of work at the community level. So Matt, take it away.
Thanks, Ann. So how do most assessment systems currently operate? We know that most systems actually are largely uncoordinated. They utilize ad hoc access forms and assessment processes, and often unique to each organization, or at least to a specific subgroup or program. They utilize an ad hoc referral process to recommend clients for services outside of their programs. And this might mean providing a client with an address or a phone number, or providing a client with a recommendation, or possibly even a case manager walking a client to another new organization. But the point is that it's conducted with little or no information about the greater community system, and it's conducted differently for each provider. An uncoordinated system forces clients in the midst of their housing crisis to navigate a disconnected and often very complicated system of care with cumbersome and confusing intake procedures. The current system is designed to answer one important question: should we accept this family or this client into our program? And I want to stress that that is indeed an important question. An organization wants to admit and serve clients that it believes it will serve well. And in the absence of knowledge about or coordination with the rest of the system, this is the best that most organizations can hope to achieve. A coordinated assessment system has 2 basic components. If there's one thing that you remember about the coordinated assessment system, it's this: a standardized access and assessment process for all clients, and a coordinated referral process for clients to receive services. This means that every provider uses the same forms and the same assessment no matter the client. And referrals are conducted with an understanding of the entire continuum of programs, including their target populations, offered services, and bed availability. Because the process is the same for every client, and because the assessment can be matched against every program in the continuum, a coordinated assessment system is designed to answer an entirely different question than an uncoordinated system. What housing and service assistance strategy is best for each household of the several services that are available? This means that a coordinated system can be both client-centric and appropriate to the immediate capacity and availability of the continuum's programs. So what does the system actually look like in practice? It's important to note that coordinated assessment will look differently in every continuum. As we walk through this flowchart together, I'm going to point out the major variations that we've seen around the country. But I want you to note that there are many hybrid systems that use different combinations of these variations, and that the system that you implement will ultimately be a hybrid, perhaps using variations of versions that we discussed here today. The key is to follow the two principles that we outlined previously: standardized access forms and assessment procedures for all clients, coordinated referral processes for all clients to all programs. In this flowchart, we're going to explore who the client or households are that receive service through coordinated intake, what type of intake strategies can be implemented that allow clients to access the system, what the assessment process under coordinated assessment needs to accomplish, the qualities of a good referral when using coordinated assessment, how the system might connect to mainstream services. So naturally, our system starts with the clients. Very handsome stick figure family here. And as mentioned before, coordinated assessment is designed to serve all clients, regardless of the subpopulation, the demographic, or the reason for homelessness. There are certainly considerations that need to be discussed when, for example, serving victims of domestic violence. An actual implementation will require an understanding of the local, state, and federal laws, as well as the needs of the culture of the community and its clients and providers. The point is that coordinated assessments are adaptable and can be designed to include everyone. Now let's look at some coordinated assessment concepts. Standardized access and assessment include two general functions, the first of which is access. Just a note on terminology before we go much further, though. I use the term access to refer to the entire entry point into the continuum of care system. Access includes all interventions and programs within the CFC, including shelter diversion and prevention, emergency shelter, and others. We've intentionally decided not to use the term intake because we don't want to suggest that this initial access point requires enrollment in a residential-based program. For many clients, access to the continuum of care can mean shelter diversion or interventions or referrals to mainstream resources, both of which may resolve the client's immediate housing crisis, but don't require enrolling the client in a residential program. The concept of access refers to the process by which clients present and enter the system. Access answers the question, where do clients go for entry, how are they received, and through what types of processes and by whom? The answers to these questions will depend significantly on a number of factors specific to your individual CFC. What we have here are four general categories that most variations fall under and that, when implemented, allow us to answer the question again, what housing and service assistance is best for each household of the array of services that are available. The first category is for single access systems, or single point of access. The systems, also called centralized intake, means that there is one physical location that performs the intake of all clients for all CFC programs. Staff are primarily, if not exclusively, intake and assessment staff and have received specific training to be able to intake and assess any person, regardless of demographics, who presents using a standardized and consistent process. Multi-site centralized access systems, sometimes called hybrid systems, come in several different variations, but they all use use a small group of access points in diverse locations rather than one centralized intake office. In some communities, the system is operated by one organization specializing in intake and assessment, just like in a single point of access system. System staff work at several different offices and might be housed as independent agents, who kind of travel around to different locations, but that use the same forms and procedures and access the system in the same way. The No Wrong Door system has many different locations and are operated by many different providers. A person experiencing a housing crisis can present at any agency and expect to receive standardized intake and assessment services. The process is still coordinated with staff committed to using the same forms and procedures and accessing the same centralized data system. Finally, there are 211 assessment hotlines that can be called from anywhere at any time and are answered according to a standardized protocol. These hotline services can provide anything from basic program information to intake interviews and program referrals. The hotline staff are trained to address the immediate needs of persons experiencing homelessness in addition to their support of individuals seeking other social services. From any of these configurations, the client is then either diverted to mainstream services, connected directly with immediate services as appropriate or necessary, or is connected with a more thorough assessment to identify the most appropriate coordinated action plan for the client. The important key here is that all answer the same question: what housing and service assistance is the best fit for each household, and not the question, should we accept this individual or family into our program? Now let's review assessment. Assessment is the second process under the standardized access and assessment component. Here, assessment refers to the detailed interview process that allows a specialist to make a specific determination about the best menu of services that fit the client's needs. The choice of an assessment tool or a set of tools is an important collaborative process that captures the collective mission of the continuum of care. It should incorporate current promising practices and the input of the entire continuum of care community. The assessment is a one-on-one interactive process performed by an assessment specialist that oftentimes will occur over a period of the first several days of contact. It's detailed enough that it can accurately report on the following. It can document the client's homeless history and housing barriers, match the client to appropriate services, capture data to meet program needs, capture data to meet further funder requirements such as HUD or other local reporting requirements, obtain consent for sharing with providers, and initiate the client's housing plan. The important outcomes are that the assessment is consistently applied to all clients, accurate and complete as possible, and that it creates enough of an historical profile that it can be useful to a case manager who will work with the client on his or her housing plan. Now let's talk about coordinated referral and assigning the client to an intervention. Coordinated referral and assignment refer to the process by which clients are connected with and enrolled in an appropriate housing and service solution. Without a good referral system, communities will not be able to reap the benefits of coordinated assessment or to answer the question, what housing and service assistance strategy is best for each household? The qualities of a good referral system include the following. They're accurate. It matches the client's current housing barriers. Informed. It matches the facility availability. If the beds aren't available, then the referral is not going to lead to an enrollment. It's effective. The provider accepts and enrolls. We know that we have met the above two criteria when the client is both accepted according to the program standards and enrolled according to availability. Standard, one process, all clients and services. It needs to be the same for everyone so that it is fair for the clients and so that it can be trusted by the providers. Comprehensive. All funder and provider fields. It needs to capture all of the most important data that funders will be required to receive and that providers need to initiate the services. This is going to prevent redundant interviewing and reduce some of the client trauma from having to repeat their story over and over again. Digital, using HMIS. If the referral is electronic, the information can be transferred immediately. Providers can access available beds in real time. Records can be transferred consistently and easily, and in the best cases, the intake specialist can receive feedback regarding service delivery connections to facilitate systems tracking. And finally, mandatory. Every provider, all the time. Whatever the referral process looks like, it is important that everyone follows it. Buy-in from providers is a critical quality of a good referral system. In many communities, that means no built-in exceptions to the process. In some, that may mean a thoughtful and intentional case conferencing process where providers or clients can question a placement made by the system so as to better serve the client and the system. But in any case, even with a built-in number of allowed refusals, the policy must be consistent across the community and adherence must be mandatory. Now that all of the coordinated assessment components have been defined, let's turn to mainstream systems. But before we turn to mainstream systems, I think there's another poll question that we can pose. If we can transition to that. So I've just gone through some of the basic components, access, assessment, and assign. The poll question that's posed here for us, what do you think is the biggest fear or concern about implementing coordinated assessment in your community? And you have a number of choices. Designing the system, giving up control over referrals and enrollment, the level of staff expertise required, the cost of implementing the system, or resistance or perceived resistance from providers in your community. So go ahead and select the one that you feel is the biggest concern or the most significant fear that you have going into your planning process or implementation process. We'll take a couple seconds while you review the options and make a selection, and then we'll report out. So it's relatively split. Level of staff expertise doesn't seem to be a major concern among most people, but the giving up control over referrals and enrollment and resistance from other providers did score relatively high. And I can say from my experience, working with a couple of communities to implement coordinated assessments, that's in line with my practical experience in working with communities. It tends to be relatively challenging to come to some kind of consensus and develop a set of management protocols that both meet the needs of the entire system, but also recognize the autonomy and the local control that providers want to retain in their programs. So these are interesting concerns, barriers that should inform the development of your process. So let's move on to mainstream services and the role that the mainstream services might play in your process. They're not represented on our flowchart, and I wanted to let you know that we haven't forgotten about them. We talk a lot about the importance of diversion when appropriate and about connecting homeless-specific services to mainstream services, and coordinated assessment systems can be developed to leverage these connections. In the coordinated assessment communities that we've observed, connections have occurred in a number of different ways with different types of partners ranging from healthcare to correctional facilities and a variety of different collaborations. But in general, they've all included a core set of common attributes. Client-level information sharing, system-wide information sharing, resource sharing and co-location, and in many cases, providers have shared resources by combining triage services with centralized intake locations. and a comprehensive community planning process. And in nearly all the communities, coordinated assessment has been part of or has been initiated by a community-wide discussion on better cross-service coordination and integration. Let's briefly review a few of the community examples. So for a single point of access system, we're going to be looking at Kalamazoo. The Housing Resource Center in Kalamazoo provides a single point of entry for all of the county's housing programs. There's a 211 service that provides 24-hour intake and referral source for emergency housing. All the clients apply for housing assistance at the HRC, the Housing Resource Center. They complete the same application form and they go through the same screening and assessment process. Staff at the HRC, or the Housing Resource Center, analyze each assessment and determine what type of assistance to offer. So families who seek emergency shelter, particularly those seeking help at the HRCs, are pre-screened for rapid rehousing. That's one of the first core interventions that they're screened for. But the HRC coordinator handles virtually all of the housing-related programs in the community for low-income people, families, and single adults. So there are an array of services that they can refer to in addition to rapid rehousing. All intake information is presented to the Housing Allocation Committee. This is a part of the Housing Resource Center. The Housing Allocation Committee oversees all offers of housing to households using the HRC. They make a final determination about the housing offers going through the HRC, as well as recertifications for extended rental assistance of 1 or more months. Another option is a multi-site coordinated system. And this example we're going to share here is from Dayton, Montgomery County, Ohio. Dayton, Montgomery County, Ohio implemented a coordinated assessment and intake system that takes advantage of 4 location-specific gateways, or front doors, to the system. Each is specific to a particular subpopulation. So for instance, they have gateways or front doors for domestic violence, for families, singles, and for youth. The Dayton Montgomery County defined a set of coordinated assessment performance standards for each program, and they tied those outcomes to the system performance measures that are aligned with HUD. Dayton Montgomery County is reducing length of stay, reducing recidivism, and improving housing placement for a more efficient and a more effective system. After a year of implementation, Dayton Montgomery County has experienced impressive results. All CFC-funded housing programs are now only accepting referrals from one of the front door system gateways. This has essentially closed the side door of referrals that previously housed clients that were not a priority population. And finally, Dayton Montgomery County was able to identify and prioritize all the chronically homeless persons for housing. Persons in Dayton, Montgomery County who are chronic can now be immediately referred to appropriate housing placement and services. That's a fantastic result in Dayton. What about a rural community, and what type of system would work best in that kind of configuration? Washington State provides an example of coordinated assessment in this type of rural environment where a single access point is not going to be realistic. There are 2 separate counties that have adopted similar goals but have implemented different systems based on their specific provider, resources, and service environment. Whatcom County identified a community resource center to conduct an initial screening process to determine eligibility for rapid rehousing and other services. Intake workers use a single intake form, and they call it the enrollment assessment, to determine initial eligibility. The intake center is operated by Women Care, which is a DV agency, and this enables the assessment and the enrollment process to address the needs of both DV families and those clients who are not DV clients. In Clallam County, clients are referred to one of 2 walk-in housing resource centers. Families are directed to these housing resource centers through 211, schools, treatment programs. There might be public human service agencies that make the referrals. But the case managers at the resource centers make decisions regarding referral based on assessment protocol that is specific to Clallam County. And a no wrong door approach in Lancaster, PA. Lancaster has adopted this no wrong door approach, and all case managers meet every 7 days in one of 8 local emergency shelters to review new intakes collected during the prior week. The case managers make formal referrals, but the client speaks directly to the intake staff person at the referred housing program to confirm eligibility. An intake and assessment is then completed when the client follows up on the referral. This can be done over the phone, so the client doesn't have to physically go there. Although all families may need to be somewhat motivated to complete the multi-stage process, housing programs have adopted a fairly broad selection criteria to ensure that families are successfully placed in all programs. So we've now listened to a couple of different options, and I want to let's transition to another poll question. And based on the general overview of coordinated access systems and the different models that we've talked about, which model do you think might work best for your community? We've given examples of a single point of access, physically centralized, 211 hotline, where it's centralized through a telephone or an information referral hotline, a multi-site coordinated approach, a no wrong door approach, or maybe you're just not quite sure yet. You need to think about this a little bit longer. So go ahead and select the option that you think might work best in your community, and we'll review the options. And I'll give you just a couple of seconds to select your choice. Looks like the majority want a multi-site coordinated approach, but there are a fair number of people who want the hotline, looking at a no wrong door, or are just not quite sure yet. Interesting that a single point of access, physically centralized, is the answer with the fewest responses. Obviously, as I said before, there is no one model, and whatever ends up being ultimately most successful in your community will likely be some kind of hybrid approach that recognizes the configuration currently in existence and the resources and kind of culture and program mix in your community, but interesting mix, or a broad mix across all the different models. Now that we've walked through the model and explored a handful of implementation examples, we need to take a step back and remember that systems change is a slow and intentional process that's going to require some thoughtful planning on behalf of the local community. The best place to start is to analyze and then document the way in which the system currently works right now. So before you choose a model, you're going to want to consider a number of questions, planning questions. What does the current access and assessment process look like in your community? Both the current access, the assessment and referral process in terms of the client flow, and also the workflow for caseworkers and for data entry and data collection. What is your continuum's geography and population dynamics? So you're going to want to look at demographics, system inventory, utilization patterns. What are the relevant programs and referring agencies in your community? Who do they serve and what do they do? What type of community resources exist, both from the mainstream systems and otherwise? And importantly, what's the level of trust, the types and depth of relationships between stakeholders? How do folks currently use data? And what's the likely planning and decision-making body? And does this entity have the authority to drive systems change? And once you have identified the important stakeholders, what are their perspectives? What are their values? All of these questions will have an important impact on the coordinated assessment system that you eventually implement. So we've gone through some sort of big picture planning questions, and I'm going to transition it back to Anne so she can maybe introduce some immediate next steps. Or maybe Christy.
Yes, we're straightening ourselves out over here. You threw us for a little bit of a loop, Matt.
Should I cover this slide?
Actually, Matt, that would be great if you could.
Okay. So as you you gather the troops, organize your thoughts, collect the data, you're going to start to do some preliminary analysis. I would expect that you'd want to look at your current inventory, your point-in-time counts, look at utilization patterns. You're going to want to hold some beginning planning meetings and with the homeless assistance providers in your community. You want to organize yourselves around a set of common principles that guide the discussion and set for you a benchmark for what a coordinated access or coordinated assessment system will look like, and how you'll know that you've achieved the goals that you've set by establishing these guiding principles up front. Once those guiding principles are in place and you've collected the data and you've begun to map out your decision-making process, I think you'll be much better equipped to jump in and start designing your system, start looking at developing some of the assessment protocols and forms that you'll need, defining the roles that different players will have, and maybe start thinking through the specific implementation steps. And having worked with a number of communities on coordinated assessment planning and implementation, I can't underscore enough the importance of upfront planning and the amount of time and energy that you spend coordinating and designing your system up front will pay off in the long run. But that being said, there's no amount of planning and design and intention that can account for every single buckle in the road and every single nuance of your system. So you're going to want to also build into your process a way in which you can check back in with providers, with clients, and with your assessment process managers, so that you can gauge the progress, make mid-course adjustments, and track the success that you achieve. Where to look for help? I would encourage you to check out the resources on the HRE. The HRE has a number of resources that will be posted in the coming months, but there also are resources that might help you currently right now in terms of helping to understand and document and inventory the system as it exists. And then finally, we've listed some specific resources here that are on the HRE, a report from the HPRP program on centralized intake. Obviously, the HARF Act will have some guidance for you, and you're always able to submit questions via the virtual help desk. These can be very specific questions related to a particular model or plan, or more general questions if you're asking for guidance or direction about where to find resources that might be helpful to you.
Great. Thank you so much, Matt. Really good stuff. And we have one last polling question related to that last point. This, of course, is just the beginning of an ongoing conversation, and we will be doing additional webinars and preparing additional guidance materials as we move forward. So we wanted to ask you all for your thoughts on what would be helpful for you as we move forward. So what other types of information would you like regarding coordinated assessment? If you could choose the one thing that you feel would be most helpful. Is it written briefs around how other communities have implemented coordinated access, additional webinars featuring community presentations, toolkits that provide sample tools and forms, or access to a community of practice or peer support? Again, we'll give you all a few seconds to respond. Great. So overwhelmingly, 65% of folks would like toolkits, so sample tools and forms, which makes great sense. There's a lot of work that's already been done in this area, so no need to recreate the wheel. And in fact, I think folks are, in fact, working on some of these sorts of resources right now. And then looks like between 10 and 15% for the other things, other webinars, written briefs, and sort of peer-to-peer support. So with that, we're going to, at this point in the webinar, turn to questions. We've received a number of questions throughout the conversation, and we're going to just sort of have a discussion here. I have a number of questions. I'm going to pose some to Ann and some to Matt. We have, we'll probably spend about 15 or 20 minutes on questions. So the first one is for you, Ann. One of the participants asked, when moving to a system level outcome process, how will the APRs be aggregated to share system-level performance when each of the HUD SHP projects are currently operating on different contract years? Could you talk a little bit about that?
Sure. I think this is a good question because it really points out the differences between sort of the old way of thinking about outcomes and the way that HART directs us to think about outcomes. So as we move forward and we start talking about performance and outcomes at the system level, that information is not going to be generated out of your local APRs. That information is going to be generated out of your local homeless management information system. And that's for a couple of reasons. One, we really want to look at the system itself as a whole and see how it's functioning. And then you could locally look at some data, let's say around the rate of recidivism. You can't ever really tell just by aggregating APRs what the rate of recidivism would be locally. You would have to really go into your homeless management information system and see, start matching exits, the client identifiers as exits, and then identify who's coming back into the system. So it's really, you have to start thinking about it in a completely different way. Before anybody freaks out there, be rest assured that we are in the process of developing a very specific set of guidance and tools that will help localities understand how to use their HMIS data and exactly the formulas that we expect people to use to understand what their system performance looks like. And so, like I was saying, you might want to look at the recidivism rate in your community and notice that, let's say, it's 15%. And then you might notice, as you look at that recidivism rate, that one or two projects specifically are generating the highest rate of recidivism, or the most number of people that are coming back into the system. That will give you, as a continuum of care, it will give you some good idea about where there are some performance issues within your system, so that you can go and talk to those providers and say, okay, well, where do we think the problems are? How can we tweak the program designs? Matt or Christy, did you want to add anything to that?
I think that's great. The other thing that I would add is that I know HUD is working on developing specific system-wide performance indicators and providing clear specifications and guidance on how to generate a report that would describe recidivism across your system, and housing retention and length of stay. And just aggregating independent APRs is not obviously going to provide you with answers to these questions, but I think we can expect clear guidance from HUD on some of the specifications for system-level measures pretty soon.
Yeah, and just to be just a teeny bit more specific on that, our plan is to provide that kind of guidance before the Continuum of Care application opens this year, so people have a chance to take a look at it before the Continuum of Care application opens. And we don't expect this to be instantaneous either. We will give communities lots of time to be able to work through the local issues related to changing, from a project-based system performance model to an HMIS-based one. And the last thing I want to say about that is that ESG programs will have to be included in that performance measurement process. So ESG folks, you're on the hook as well.
Great, thanks, Ann. Matt, the next question I want to pose to you is sort of naturally a lot of trepidation as we move forward into somewhat uncharted territory, and some folks are asking what your experience has been regarding how long it takes communities to transition to a centralized intake system, and then as a second sort of follow-up point or question, what has been your experience, or what thoughts do you have regarding how to get service providers to give up their own forms and systems and move to a standardized process?
Yeah. The transition time is going to vary, obviously, from community to community, and on the model that you select in terms of the coordinated assessment process that you're planning to implement. The more significant system-wide changes in terms of the referral process, the enrollment process, the prioritization of clients coming from a centralized waiting list, those kinds of concepts. The more significant that is, the longer it's going to take. In some communities where I've worked, they've spent almost a year in their planning process. I know it's just not practical in many communities to spend a year planning. But, as I said before, the more time you can spend up front to design your system, make sure that everyone is on the same page and that you, to the extent possible, have consensus on a common vision or guiding principles, it's really going to put you in much better stead to be successful later on. I think in general terms, if you started right now from scratch and wanted to have some significant system-wide changes in place, you're looking at a number of intensive months of planning and then maybe a short kind of transition period or pilot period. And my guess would be that an appropriate amount of time on the shortest end would be about 6 months. But again, this is going to vary from community to community. The second part of that question is how to as we all know, each provider has over time developed a set of forms and processes and program models that are specific to their program design, to their staff, and to their agency, and they become particularly accustomed to them. And it's a very awkward and sometimes uncomfortable feeling to give them up and to adopt a more universal form that may in some instances feel watered down or not specific to your population or to your program design. And I would say that it gets back to the core question that we pose about the reason for coordinated assessment to begin with, and transitioning our thinking about what's best for my program and how do I make the best decisions for enrolling clients in my program, turning that question around and thinking about what's best for the client that's in front of me, that's coming to my program, and that's accessing an entry point. And in order for us to have a client-centric system in which we're making decisions in the best interest of the client, it requires that we have, obviously, more coordination, and we give up some level of specificity and control over our own forms and adopt ones that can be used more universally by a number of different providers. We're going to be providing, obviously, in the guidebooks and tools that HUD is releasing, we'll be providing some examples of what a universal or coordinated or intake form might look like. But I do want to caution people that it requires that you go through your own community planning process and develop forms that are specific to your own community. It would certainly be easier to just adopt wholesale a form or a process that another community has developed and tested and is successful in another community, but it doesn't necessarily translate to success in your own community. So even though we'll provide you with examples of forms, of templates, of checklists, of guides, they really are just a starting point for the conversation, and we encourage you to use those to inform the development of processes and forms that are specific to your own community.
Great, thank you, Matt. The next question I'm going to pose to Ann. We've gotten a lot of questions around funding for coordinated assessment. One participant acknowledges that there will certainly be startup costs, and several folks are wondering, is reallocation the only way to pay for this, or will this be a funding option under the Continuum of Care program under the 2012 application? So Ann, could you talk a little bit about some of the options that are available to communities?
Sure. You are at a little bit of, as am I, at a little bit of a disadvantage because you don't yet have the Continuum of Care interim regulations in front of you to take a look at. But here's what I can tell you about how we've been thinking about funding this kind of implementation. There's a couple of different funding sources. If you have had a chance to look at the Emergency Solutions Grants regulations, you'll see that we basically treat the coordinated assessment system as case management. So under the ESG program, you can use case management funds that are under street outreach, emergency shelter, homelessness prevention, or rapid rehousing in order to use the centralized or coordinated assessment system that you develop. Under the continuum of care, there's a couple of different options, and you will see it laid out in some detail in the preamble of the continuum of care rule, as well as within the regulatory text once you have access to that, which again will be probably in the next, I'm guessing, 45 days or so. And so I would first ask that you comment on items within that rule that that specifically relate to this issue. We have asked a couple of specific questions related to centralized or coordinated assessment within the rule, so please respond to those. But what we're saying in the continuum of care rule is that there are planning costs or planning dollars that are being allocated to the continuum as we've talked about in some detail in other webinars and through our conferences. So since continuums are actually going to be eligible to receive planning dollars, the planning for implementation of one of these systems or models is going to be eligible under the 3% that is, or up to 3% that is allocated for continuum care planning. At the project level, as with ESG, we're going to consider it case management. So even though it's not specifically called out within the ESG rule or the COC rule, it is considered a form of case management. And we'll be providing, once we roll out the continuum of care rule and we do our first set of webinars on that, we'll be providing a lot more detailed information on how to budget for these types of activities.
Great, thank you, Ann. The next question I'm going to pose to Matt. Some folks are wondering how communities with existing coordinated entry systems have overcome obstacles related to confidentiality and data sharing. And more specifically, one person asked if there's any recommendations for how to do a release of information using a telephone or a centralized 211 hotline system. Matt, do you have any thoughts on that?
Well, in a coordinated assessment system, obviously a greater amount or a greater extent of information sharing among the intake staff or the assessment staff and the referring agencies is going to benefit the system. It certainly benefits the client because it streamlines their access to these programs and the enrollment process. So I think first off, just in answering the question, I see data sharing as both important and beneficial to clients. Many communities have a variety of different consent protocols in place, but the baseline standard for consent is inferred consent. And clients entering a system and requesting initial support through whatever intake process has been defined, you're able to, given the baseline consent protocol that's been established with the data standards, you're able to collect the appropriate information and enter that information into HMIS and make determinations about the appropriate referral, all in an informed or in an inferred consent environment. So it really does provide, the baseline standard does provide a great deal of flexibility in managing individual case planning with clients and in designing your system in the most flexible way possible. Now, obviously, we have, as homeless assistance providers and as system planners, we have a great deal of responsibility to manage this protected personal information in an appropriate and a secure environment. So you're going to want to obviously take the necessary precautions and implement the necessary protections so that clients feel protected and they feel that their information is being used appropriately and disclosed only when appropriate, and that those uses and disclosures are spelled out, clearly articulated in your privacy policy for your community, and all of the people in your community are trained in them and appropriately adhering to those policies. Now, given different situations in various communities, there might be local privacy considerations, statewide laws that impact the amount of sharing or the consent protocol that's allowable. And so you'll have to do some investigation, and I'm assuming most HMIS implementations have actually already done some level of research into this and have designed their protocols with that in mind. But as you think through the design of your coordinated assessment system, I would encourage you to adopt as open a data sharing policy as it is palatable to your community, is as allowable by local law, and is manageable within your continuum of care infrastructure and your HMIS system.
Great, thank you, Matt. And actually, I'm going to piggyback on this question and ask Ann to talk a little bit more specifically around challenges related to data sharing and referral for DV providers. We know that that's sort of a common sort of question or challenge or fear that communities have, and it's one that's raised often. And on a related point, then, you know, other folks are asking things like, what leverage does a continuum of care have in making participation mandatory across different types of providers, and how does all of this relate to fair housing issues? So there's sort of a lot of questions intertwined there, but I think they're all very important issues. So if Ann, you could talk a little bit about these things.
Sure, and I'll start out with you know, backing up and talking a little bit about what the Hearth Act statute provides in terms of new authority for both HUD and the continuum of care. And you know, if you were to read the statute, and you will see reflected in the regulations when they're released, that now that there is actually planning, there are planning dollars associated with the continuum of care. A continuum of care will have a contractual relationship with the Department of Housing and Urban Development in a way that it has never had before, because we have, you know, historically only provided grant agreements or contracts with the grantees, regardless of whether that grantee was also the lead agency within your continuum of care. So within the requirements that are going to be laid out both in the Act and in the regulations, you'll see that continuums will have a series of responsibilities. And therefore, that actually gives the continuum regulatory authority to oversee the continuum of care that they don't currently have. As many of you know, the continuum of care as it currently exists only exists administratively. We implemented it at HUD through the continuum of care NOFA, but it didn't really have a basis in regulation or statute. So now that it does have a basis in regulation and law, it actually provides you all, the continuum of care leadership and the group of folks who are making decisions on behalf of the continuum of care, it provides you some authority to make decisions and to ensure that the local policies are being followed to the extent that they should be followed. So the rule itself will lay these kinds of responsibilities out. It's not incredibly prescriptive, but there are some very key items that I think folks won't be, you know, surprised about, but that we would expect continuums to do. So that's really what leverage the continuums might have to ensure participation. And, you know, in addition to that, on the ESG side, because we're expecting their participation as well, it is a regulatory requirement, which means that HUD can monitor for it and make findings against grantees if they do not participate within, you know, the required systems. So that said, we have really been working hard on the issue related to domestic violence that one of our participants asked, as well as the issue of fair housing. And we've spent a lot of time talking about these two issues because we know it really impacts you at the local level. In terms of domestic violence service providers, we have asked for and will continue to ask for specific feedback from DV providers who, you know, on whether they want to participate in a local coordinated assessment system and what the implications would be for victims of domestic violence outside of a domestic violence service provider. So right now, DV service providers are not required to be in HMIS, and they're not going to be required to be in a coordinated or centralized assessment system. but there are victims of domestic violence that are coming through the system outside of those particular organizations, and we are concerned to ensure that the safety of those domestic violence victims is protected. So we have actually asked the community to provide us feedback on that, and we'll be reflecting that in upcoming technical assistance materials and tools once we're able to get that feedback and take a look at it. Right now, I think that we always err on the side of the safest option for domestic violence victims coming through the system. But again, ESG providers, who are right now the only ones that have interim rules out there, are not required to have a centralized or coordinated system, because that's really going to be the responsibility of the continuum of care to implement. Around the issue of fair housing, which is related but not exactly the same, we have also spent a lot of time talking about how our programs are going to be in compliance with fair housing rules, and the preamble of the continuum of care rule lays out over many pages what decisions the department has made and what the policies will be on the issue of fair housing. So I would just ask you to hold up and take a look at that when it comes out, and it will give you lots of examples as well on the issue of fair housing.
Great, thank you, Ann. I think we have time for one last question, and it's another tough question, and it's related to the information that Ann just provided around how do you encourage or incentivize providers to be part of the system. Well, Ann talked about how you do that for HUD-funded providers, but non-HUD-funded providers are sort of another issue. So Matt, do you have any suggestions, or in your experience, what incentives or opportunities are there to encourage non-HUD-funded providers to participate in a coordinated assessment system?
I'm glad this question came up, because in the experience in the communities where I've worked with coordinated assessment, this is a significant issue, and I think most communities that are going to be struggling through their own process will encounter this at some point. The way in which that I found to be most successful to manage those, either those providers who are really sort of just entrenched in doing things the existing way and find systems change really difficult to adjust to, or might make the argument that they're serving a particular subpopulation, or they have a funding source, or they don't have a funding source that would suggest that they don't need to be part of the system or part of coordinated assessment. In all of these instances, what I found to be particularly helpful is to engage them, even though they initially will say that it doesn't make sense for them, or they're sort of intractable and they don't want to participate. Engage them in a discussion about developing some guiding principles for the continuum. Even if they're not going to participate in coordinated assessment, they can at least agree to a set of core values, core principles that describe how the continuum wants to address the issue of homelessness, and the role that all of the service providers play in creating a cohesive, coordinated, intentional system of care that deliberately links clients who are in the midst of a housing crisis to the best resource available to them. If they say, they're not going to participate, at least they have to, or they're engaged in a discussion about adhering to a set of guiding principles. And when you have conflict, or you have providers where there's some struggle, you can always refer back to those guiding principles, and at least you have a common framework or a common foundation to start over again and begin the conversation about what systems change will mean for them, and what amount of adjustments or refinements or changes they're willing to make or can make as the community moves forward in implementing coordinated assessment.
Great, thank you, Matt. Well, it looks like we're starting to run short on time, but I really want to thank everyone for participation in today's discussion, and a special thank you to Ann, Matt, and all of their staff who helped us develop the content for this webinar. We hope that was helpful to you all, and as I mentioned earlier, this certainly is not a one-time discussion. This is just the beginning of a lot of work moving forward, and in the coming months, please be on the lookout for additional webinars information on best practices and additional new written resources, which again will make available on the HUD HRE, on our website, and through our partners. As always, we appreciate all of the hard work that is happening in the field, and we appreciate partnering with you all. And with that, I wish everyone a great afternoon.